Good morning, good afternoon, and good evening, everyone, from wherever you're joining around the world. Welcome to the launch of our new report, Protecting Mental Health from Extreme Heat, Recommendations for Policy and Action, a report by United for Global Mental Health in collaboration with Climate Cares at the University of Oxford and Imperial College London and the SPARK Lab at Columbia University. My name is Alessandro, and I work as a senior policy and advocacy advisor at United for Global Mental Health, where I lead our work on climate change, the environment, and mental health, and I'll be moderating this session today. First of all, I wanted to thank you so much for joining this webinar and for showing interest in this topic. I'm joining from Italy today, where we are experiencing yet another heat wave this week, like many other countries in the European region and countries from all over the world. And I think this highlights how timely this topic has unfortunately begun. We wish this wasn't the case, but we're also very grateful to see so much interest in today's webinar, with so many people joining us today. Before getting started, I wanted to welcome you on behalf of United for Global Mental Health, but also walk you through a couple of housekeeping rules before passing it over to Francesca Raccioppi from the World Health Organization for her opening remarks. So this webinar is being recorded, and the recording will be shared after the event. Given we're using the Zoom webinar function, as attendees, you will automatically remain muted with cameras off throughout the session. But please submit any questions you have using the Q&A function at any time during the webinar. We'll answer as many questions as we can during the discussion at the end. The session will last approximately 1.5 hours. We will start with some opening remarks by Francesca Raccioppi, Head of Office at the WHO European Centre for Environment and Health, followed by a presentation by Olivia Biermann, who will provide an overview of the key findings from the policy brief. We will then have an interactive panel discussions with a Q&A dedicated session. So I'll now pass it over to Francesca for opening remarks. And thanks again, everybody. It's really such a pleasure to have so much interest in this important intersection. And thanks so much again for joining. And Francesca, over to you.
Thank you very much, Alessandro. And it is a real joy, it's a pleasure and an honor to be given the opportunity of opening this webinar. You will let me start by warmly, sorry, it sounds like a joke, but yes, a warm congratulations to United for Global Mental Health, Climate Cares, and SPARK Lab for bringing to us this latest evidence, which is so hugely important. I will try not to spoil the pleasure of diving into the detail of the report, because this will be highlighted in a few seconds. But just let me say a couple of words about the context in which this is all happening. You heard Alessandro. Alessandro is connecting today from Italy. Today I'm connecting also from Italy, from Rome, which is the city where I was born. We are at 35 degrees. And today it is not really that bad. It could have been much worse than this. And we are you are launching this report at a very, very, unprecedented time, because this is perhaps the first year when we have seen extreme temperatures here in Europe manifesting themselves already in June, in the second half of June. And as we know, this is a part of the trends that tell us that heat waves are starting earlier, will be more protracted, are more intense, and they last longer each time. And in fact, as I'm speaking, I was, a few minutes ago reading about France, where now they are grappling together with Spain against devastating wildfires, where additional issues are posed by the fact that they are entering yet a new heat wave approaching. So we do know that the heat kills. I was last week at the European Commission. There was an event to commemorate on the 15th of July the victims of extreme weather events, several hundreds of them in Europe in 2021 because of devastating floods at that time. But we have dozens of thousands of deaths every year related to the heat waves. Last week, the count was around 14,000 deaths attributed to the early heat waves. But this is, this is just in a way not even 1/4 of the season. So we will keep counting. And while we are getting better at counting deaths, we are not yet there at quantifying the effects, the broader effects on which, of course, are, we have the deaths are the tip of the iceberg. Whatever lays below that is a lot of disease. And the effects on mental health in particular are not yet fully understood and fully quantified. But we do know that extreme heat is extremely bad for mental health and well-being. And it is so particularly for the populations who are already suffering from mental health conditions. So heat may increase mortality among people with mental health conditions. We see an increase in hospital admissions and emergency departments visits in connection to, increasing psychiatric disorders, not least because people don't react the same way as they do normally to medicaments, increased suicide risk. But then we also have millions of people who are not having a diagnosis of mental health conditions, whose mental health well-being is being affected by the extreme heat. Just think of people who cannot sleep. Sleep deprivation has important health effects. People who cannot study, who cannot concentrate, who cannot perform the way they would normally if the temperatures were normal. And this summer, because the heat wave was so early, we have also seen several countries closing or changing the opening times of schools and daycare centers. So this is why at the WHO, we have taken a special look and a special attention to the effects of mental health, of climate change on mental health, as we have been revising and publishing our latest guidance for the development of heat health action plans. This revised guidance was published just a month ago, and it is making sure that mental health must be squarely part of the continuum of all the steps that are necessary to develop and to implement well-functioning, well-coordinated, and end-to-end heat health action plans. This is why when Alessandro invited me to give these opening remarks, I was super excited because your report, this report, is telling us very important messages. And one of that is that we are not yet where we would need to be when it comes to integrating mental health into heat health action plans. You have revised and reviewed more than 150 of them, and then I'm only quoting one single number because, as I said, I will not spoil the pleasure of the findings, but only 14% of these heat health action plans are addressing mental health the way it should be. So this means that there is a huge amount of work for all of us, for public health professionals, mental health professionals, the communities, those who are part of the early warning to response and identification of vulnerable groups, a lot to do at the community level, at the professional level, at the clinical level. And this is a very important, big agenda for all of us. At the same time, however, there are good news because we know that there are things that work and they work well. Therefore, the prevention and again, paying the full attention to from the preparedness to the response will be key in helping us to adapt to what is happening and reducing the risks to the population at the risks. To conclude, then, I will just say that there is no doubt that the heat is affecting our world, some parts of the world more than others, but it is an ubiquitous problem. It is something that has profound and not yet perhaps fully uncovered impacts on mental health. We do know that surveillance, early warning, targeted outreach, preparations and training of the health professionals, and continuity of care can help saving lives, can help keeping a better quality of life, and giving us and keeping us functional and in good mental health and well-being throughout the heat waves. So I'm closing, inviting all of us to keep forward this well, shall we say battle? Yes, it is a battle. It is a battle when you have to face deniers, science deniers. It is a battle when you have to fight for budgets. It is a battle when you need to fight for political attention. And we are together in this trench. I hope succeeding as quickly and as soon as possible. Thank you very much, Ale.
Thanks so much, Francesca, for these opening remarks, for really, I think, laying the ground when it comes to impacts, as you mentioned, but also about the available solutions that we have available. And thanks for joining us on this journey. So we'll now hear from Olivia Bierman, who really led on the development of this policy brief and who really deserves most credit for it. Francesca mentioned a couple of snippets from the report, but Olivia will provide a brief presentation on some of the key findings that have come out of this policy brief. So Olivia, over to you.
Thank you so much, Ale. Let me just pull up my presentation. Can you just give me a brief thumbs up that you can see it?
Yeah, perfect.
Okay, great. Thank you so much. So welcome everybody also from my side for joining us today. I'm so excited that we're finally launching this report. And my name is Olivia Biermann, and I worked as a policy consultant at United for Global Mental Health to develop this brief. Before I dive into it, I just want to take a moment to acknowledge the incredible team behind this work, because this was truly a collaborative effort. I'm deeply, deeply grateful to Emma Lawrence, Neil Jennings, Nikita Nalawade, Robbie Parks, Alison Stewart-Ruano, and Alessandro Masazza, whose expertise, guidance, and support have really shaped every part of this brief. And I feel very lucky to have worked alongside such a talented and committed team. Oh, my slides are moving. I don't know if you can see the correct slide. But let me give you an outline of the presentation. I will start with an introduction to the policy brief, focusing on the key findings, and then we'll look into how mental health is currently addressed, and I'll briefly walk you through our 4 recommendations as well. The policy brief has 3 core aims. It's a bit strange. I don't know, Ale, do you see my presentation moving? Because I'm not moving it myself. It's a bit...
I now see the presentation outline.
Okay. It's moving a bit back and forth by itself. I don't know.
There you go. I think there's
okay. Okay, let's continue with the aims. So the policy brief has 3 core aims. First, to give a snapshot of how, or rather how poorly, mental health features in existing heat action plans. Second, to show concrete examples of integrating mental health into heat action. And third, to equip policymakers with practical, expert-developed recommendations they can act on. And the brief draws on a review of 143 heat action plans worldwide, an open call for case studies, and expert roundtables involving more than 60 specialists from public health, climate science, mental health policy, and lived experience, many of whom are here today. The headline findings paint a stark picture. Of the 143 heat action plans we examined, 57% mention mental health in some form, but only 24% mention it in a meaningful way. 18% identified people with pre-existing mental health conditions as a as an at-risk group. And just as Francesca picked as like the main stat, it's just 40% that include concrete interventions. Now jump to the case study slide. Apologies, this is moving. Let me continue. So despite the policy gap, there are inspiring examples of action on the ground, and we have 6 case studies that span 4 continents and illustrate very different approaches. So for example, in Canada, 140 frontline mental health workers were trained to prevent heat-related illness in people with severe mental health conditions. In South Australia, a warning system with daily welfare checks showed a benefit cost ratio of $2 to $3 return for every dollar spent. In Pakistan, community mental health teams adapted care routines to heat waves, preventing hospitalizations. In Delhi, interventions for homeless people reduced heat-related distress. In Barcelona, green roof projects are cooling the city while strengthening community mental health. And in Bangladesh, the Red Cross reached 15,000 people with psychosocial support in 13 days. And I'm glad that some of the case study authors are on our panel today, so we can look forward to additional insights they'll provide, and you can ask questions as well. Now let me move over to our 4 recommendations, and I'll give you a bit of background and then show you the suggested content that we put out in the brief. So our first recommendation is to recognize the negative impacts of heat on mental health in the first place. The evidence is clear and growing. Heat waves are associated with a 9.7% increase in psychiatric hospital admissions. Suicide deaths increased by 1.5% for every 1 degree Celsius rise in mean monthly temperature. And the mechanisms span biological, psychological, and social pathways, and the burden falls hardest on those already most disadvantaged. So we are calling on policymakers to include the following in their heat action plans. Extreme heat negatively impacts mental health by worsening population level psychological well-being, for example, negatively impacting mood and sleep, contributing to worsened symptoms of mental health problems, resulting in increased levels of emergency department visits and hospital admissions, as well as higher risk of suicidal behavior. And these impacts are not distributed equally, with certain groups experiencing worse impacts. Our second recommendation is to explicitly highlight the heightened risk faced by people living with mental health conditions. During the 2021 heat dome in British Columbia, for example, people with schizophrenia faced a 3-fold increase in mortality risk. Social and economic vulnerabilities like poor housing, isolation, limited access to cooling compound the risk further. And this group is among the most exposed and the least protected, and they deserve to be named explicitly in plans and not buried under a general list of vulnerable populations. So the language we recommend is people living with mental health conditions, particularly those whose conditions are severe, are among the groups at highest risk from the impacts of extreme heat. They often experience worse health outcomes of heat-related illnesses and higher heat-related mortality rates. Now, over to recommendation 3. We need to monitor the mental health impacts of extreme heat systematically. And right now, we are largely flying behind. An analysis of European heat surveillance systems found that there were no examples of mental health impact monitoring, not one. So we need to link weather and climate data to mental health outcomes, crisis line calls, suicide rates, hospital admissions, and emergency presentations. For example, the UK ONS heat suicide indicator, now endorsed by the UN Statistical Commission, shows that it can be done. And we are asking that plans include the following. It is essential that the mental health impacts of extreme heat are regularly assessed to inform timely, relevant, and effective adaptation responses. To do this, it is important that heat morbidity and mortality surveillance system include disaggregated data on mental health outcomes, and weather and climate data are linked to appropriate mental health indicators. Our fourth and final recommendation is to ensure that tailored evidence-informed interventions are in place and properly resourced. This covers 3 levels. First, protecting people during heat waves through early warning system and targeted outreach. Second, adapting health systems through training, heat resilient facilities, and adapted suicide prevention plans. And 3, addressing structural drivers through housing rights, urban green space, labor protections, and research investment. And the overarching principle we recommend enshrining is multiple evidence-informed interventions exist at different timescales that can be co-designed with affected communities and integrated into existing systems to protect mental health during extreme heat. Now, let me close with this. Mental health is the hidden toll of the climate crisis, and it remains almost entirely absent from the heat action plans that are meant to protect us. Around 160 countries still have no heat action plan at all. So as new plans are developed, mental health must be included from the start. And now let's dig a little deeper into some of those questions during the panel discussion. Thank you very much, and back over to you, Ale.
Fantastic. So thanks so much, Olivia, for this overview, and especially for all of the work that you've done on this policy brief. The link of which you can also find in the Q&A, it has been shared as part of the Zoom registration email, and we'll also be sharing it again in a follow-up email. But if you want to dig a bit more into the report, you can find it in the Q&A. I hope Olivia's presentation gave you a flavor of what's inside it. And as Olivia said, we'll now move into our moderated panel with some fantastic speakers who contributed in different ways to the brief, whether by providing their own individual experience of how heat impacts mental health, highlighting real solutions they have implemented in their own local context, or by helping us in developing the policy recommendations. Before starting, I just wanted to remind everyone to ask your questions via the Q&A function, and we'll try our best to answer as many questions as we can during the panel session. So if Ayushman, Emer, Nida, Kimberly, and Samantha, you want to put your video on. To begin with, I'd like to ask the panelists to briefly introduce themselves. And I would also like to briefly know from each of you how you first became interested in the heat and mental health space. So maybe we can start with Ayushman, followed by Emer, Nida, Kimberly, and then Samantha.
Thank you, Alessandro, and congratulations to the entire team for the report. It's been so nice to read it, and it kind of summarizes everything that we discussed and we worked on. So I'm Ayushman, and today I'm representing the Housing and Land Rights Network here in New Delhi, India, where I work as the Director of Research and Strategy. And just to give you a little bit brief introduction about the organization that I work with as well. So for the last 26 years, we've been working on facilitating the realization of the human right to adequate housing and land for all marginalized groups in the country. And we have been noticing for the last several decades while we're working on evictions, the impact that any housing rights violations has on the mental health of the people that we are working with. And especially in the last 5 years, as heat is becoming an increasingly challenging, aspect for our communities that we work with, especially those who are living in informal settlements and in homeless shelters and on streets, we've been noticing how much of a challenge extreme heat is posing for these groups. And therefore, we decided to think about the mental health aspects along with the physical health aspects of extreme heat on homelessness. And that's why I got interested in this issue.
Thanks so much, Ayushman. Emer?
Hi, Ali and Olivia. Thanks so much for inviting me to be here today with you all, and congratulations on the report. It's great, as we said, to see everything brought together into such clear recommendations. So my name is Emer O'Connell. I'm a public health specialist. I've worked across the intersection of environment and health for probably about over, like 30 years now. But increasingly, I guess in the last 10 or more years, I've been focusing on climate and heat health, particularly. in my current role, I lead on health across environment and resilience for the Greater London Authority Group, and most recently embedding health equity in Heat Ready London, which is a citywide vision for heat adaptation for the city. And in my previous role, I led the extreme events and health protection team for the UK Health Security Agency. So delivering and leading the policy and operational response to heat and public health across the system, including the impact-based warning systems for heat for England. And I guess across my public health professional life, the core focus of that has been around that intersection around what drives health inequalities where environmental determinants are involved. And in my public health training, I always viewed physical and mental health as a parity. Would always be a consideration, like how are the health outcomes, how do we arrive at these health outcomes? What are the drivers for those things? And it's clear that within the climate agenda particularly, mental health has been neglected for quite some time. So I was really keen that this policy report was published and to engage with that. So it's great to see it out there. It has been neglected, but as we've identified and has been highlighted, the evidence for this being such an important part of that climate and heat priority list is now really evident to take forward. So thanks for providing us with a nice framework to work on. Thanks. I think it's Nita next. Thank you.
Hi, thank you, Elaine. It's a pleasure to be here and congratulations on the policy brief. I'm really excited for it. So my name is Nita Wasim and I work as a research specialist. And my interest in climate and mental health actually is inspired from both my professional journey as a public health researcher and lived experience that I have been living through in this warm climate temperature that we live in. I live in Karachi, and for most part of the year, we have been facing these prolonged heat waves and extreme temperatures. And being a researcher, I have noticed and I have seen that we have been talking a lot about the physical impacts of heat and other climate disasters. But mental health is something that has been missing from the conversations, and it's been missing from the evidence. So this is where I wanted to contribute, and this is where my passion lies. And I hope that I continue to contribute meaningfully to this. Thank you.
Thanks so much, Nita. Kimberly?
Thanks so much, and thanks, Ali and Olivia, and congratulations on this fantastic work. It's so very important, and I think that's evidenced by how many people have come along to this webinar. So I'm Kimberly Humphrey. I'm from Adelaide in South Australia. I am a senior emergency medicine specialist and a public health medical consultant with SA Health, our public health system, where I lead the climate change and health work. I'm also co-chair of Doctors for the Environment Australia as well. So my interest in this started clinically because my background, as I said, is an emergency physician, although I now kind of bridge those two worlds where I work clinically, but I also work in that policy space where I'm involved with the broader public health and, of course, our heat health warning systems. Really striking to me, in an emergency department, during a heat wave, and we do see a lot of heat waves in South Australia, it's very apparent that those that we are seeing most of, or those that are presenting often the sickest, are not those that we might typically think are the most physiologically frail. So it's not always the elderly, it's not always those who are coming in with dehydration or heat stroke. Often it's those who are the least supported. We see those people who are on psychotropic medications that interfere with thermal regulation. It's people presenting with a worsening of their mental health. It's the increase in gender-based violence that we see and all of the associated impacts on people's health from that as well. And then, of course, the eco-anxiety, the depression, all of the other mental health impacts as well. It's very real in the clinical work that many of our healthcare workers face day to day. I think the 2009 heat wave we had in South Australia was very formative for many of us working in this space. It killed hundreds of people across the southeast of the country. And the response that followed in South Australia really built the heat health warning system that does feature in this report. One of the reasons that I became very interested in this space and what struck me over the following years, and I think this is true globally, is that we've gotten much better at the physical side and barely moved on the mental health side. And that gap's really what brought me into that work and exactly what this report puts the numbers to and why we need to escalate what we're doing. Thank you.
Thanks so much, Kimberly. And Samantha, over to you.
Yes. Hi. Hi, everyone. I'm a family doctor in downtown Toronto, and also actually, Kimberly, the president of the Canadian Association of Physicians for the Environment, sister organization for, and I see in my primary care practice the impacts of heat on physical health, on mental health. But what really drew me actually to this work was the devastating outcome of the 2021 British Columbia heat dome on people living with schizophrenia. So, people living with schizophrenia, as you already heard, had a threefold mortality rate. More than 600 people died in 5 days, and 150 were people living with schizophrenia. Just a shocking number. So when I saw that, and when my colleagues saw that, I'm co-located actually with a psychiatric outreach team in my primary care practice. So I work very closely with psychiatrists. So we decided we had to at least do something, whatever it was that we could do in our practice. So I'll talk more about that later.
Thanks so much, everybody. And I mean, I think it's so impressive to see the variety of expertise and experiences that I think you bring to the table. But also, I think what touched me was also the very sort of personal reasons of you seeing these impacts in, your own individual professional and personal lives, and that motivating you to do more work in this space. I think something that, cuts across what most of you said is that we've seen so much excellent sort of research and evidence on the impacts of heat on health. But historically, these have really focused a bit more on things like mortality, heat stress, and other sort of physical health outcomes. And mental health historically has been a bit more neglected in the space. So maybe I'd like to start with you, Nida. You, as you said, you're based in Karachi, Pakistan, where temperatures reached over 46 degrees centigrade just a few months ago. So you're no stranger to high temperatures. And we've known about the physical health risk of extreme heat for a long time, but mental health has received much less attention. Why do you think that's the case?
Thank you, Alessandro. I think it's a very important question. And mental health is something that has been historically under-recognized. And we know that in many places, it still carries a lot of stigma around it. And we have become really good at measuring the physical impacts of heat, whether it's dehydration, heat stroke, increased emergency department visits, mortality. We have become really good at the exposure risk assessments due to heat, but what we are missing is the human experience of living through heat. And I think all these indicators that we talk about, the physical indicators and the data we get is very important, but they don't really tell the whole story. And when we talk about the mental health challenges that are due to heat, it's not like physical impacts. And unlike heat stroke or dehydration, other than the severe mental health crisis, we don't see many mental health impacts leading to an emergency department visit in most part of the world. And they are really captured in the mortality statistics or the routine data that we have. So instead, they disrupt the daily lives, the daily patterns through disturbed sleep patterns, increased irritability. We know that people face emotional exhaustion and difficult concentrating in their daily routine and daily tasks. But it still remains invisible from the data that we use to guide our policies and responses. And I think the other thing is also that like living in Karachi, experiencing heat waves throughout the years, what I experience and I've seen communities happening is that we have this tendency to normalize these experiences. And one of the biggest thing behind this, the factor behind it is that we don't acknowledge mental health as an issue. So I think that it's really important to understand and acknowledge that mental health does get impacted by the extreme heat. There's a phrase that I keep going back to, that if we don't recognize it, we don't measure it. And if we don't measure it, we don't plan for it. And I think this is what is happening here. Because the kind of responses that we generate, the mental So I think it's only natural that the heat action plans and the responses that we are coming up and that we are planning are naturally more focused on the most immediate and most visible consequences, which are definitely the physical consequences of heat. And somehow that missing piece is still not there. And I think the good news is that there is a lot of evidence that is growing. There a lot of evidence that is out there, and there are so many efforts like this policy brief to get this issue into highlight. But I think the real question is that how quickly these policy briefs can impact the heat action plans and the policymakers to actually integrate mental health into the heat action plans and treat mental health as an equally important component as physical health. Thank you.
Thanks, Nida. That's a really helpful perspective, and I think you touched on so many, I think, specific points around the stigma around mental health and how that impacts awareness and discussions around mental health in a more general sense. The point you made about data, I think, is a really important one, and the fact that globally mental health is one of the areas for which often we have the least data, and historically in the climate and health space, this kind of lack of mental health data has been often a big sort of barrier to being able to link climate and weather meteorological data with mental health impacts. But also I think what you mentioned around maybe some of the sort of invisibility or the complexities of mental health and how it's conceptualized, the fact that it's not only about mortality, but it touches on things like sleep, mood, and all of these kind of different impacts that might be more challenging to quantify. I don't know if anybody else has sort of thoughts or reflections around why mental health may have been, more neglected in the heat space. Emer.
Yeah, I agree with what Neela said, but I think there's also been an issue with policy and operational leads like to understand what the solution to a problem looks like. And it hasn't been entirely easy to determine what that is, particularly for some of the groups who are at high risk. So we know that people with schizophrenia and psychosis are amongst the most difficult and underserved of our high risk populations. They have a very, very low level of life expectancy, poor health outcomes in general. And so I think there's been some reticence about what it is that we should do. And I wouldn't understate the role of stigma as well. I think that's a really important point here. Many of these people are really deeply socially isolated, and I think that is a barrier. So it's the what to do and how to do it effectively, I think, have been critical questions. But I don't think that's a barrier to action. I think when we, as public health people and as people with roles in addressing this problem, if we know that there's a problem and we don't know what the solution is, we're beholden to design solutions, test and implement them and evaluate them. And I think the inertia has been a problem. We've known about the impact of the Canadian heat dome for a long time now, and we've been quite slow to respond to that risk. So I think that's probably a little bit to do with stigma and the lack of a clear solution about what to do.
And Emer, maybe then I'll stick with you in terms of this point you made around, the kind of sort of lack of evidence, not necessarily, or sort of the emerging nature of the evidence and not having necessarily to be a barrier to sort of acting and protecting the mental health of communities. And, your work obviously focuses on translating evidence into policy, and in your case, for one of the largest cities in Europe, London, which is also currently experiencing unusually warm temperatures as we speak. Our report makes a number of recommendations, as Olivia highlighted, but I'm sure that as a policymaker, you're asked to do many things all the time. So if policymakers could implement just one of these recommendations over the next years, which one would you prioritize and why?
Yeah, thanks. I think my priority would be determined by the context in which I operate. So that has to be taken on board. And we have the benefit of having a really well-established infrastructure around early warning systems and surveillance and data and evidence. But I do think that much of the evidence and data that we see internationally, so for example, the evidence from the Canadian heat dome to me was a significant lever to get moving on this in terms of my own role. What we are often asked as public health professionals is there sufficient or insufficient evidence to take action? And I think that this this problem has long surpassed that threshold. So recommendation four for me is definitely the one that I would prioritize personally in the context that I'm working in, and indeed that is what we are doing as part of Heat Ready London. So in terms of the process, we've gone through Heat Ready London is a citywide vision, but in parallel, I've been leading the development of a heat health action plan, and so mapping the gaps and evidence and the context of London using that WHO framework and the new the recently published UN governance framework as well, which I found really helpful as a guide. And so through that, we've identified a critical gap. Well, we're setting up a heat health partnership across London to try and address some of these issues. But within the actions that we've arrived at is based on the evidence and stakeholder analysis, is that we're going to embed heat risk management within the care pathways for people with severe mental illness in London. So it's really clear that it's not sufficient to rely on your emergency planning infrastructure for this. The deaths and impacts happen very quickly, and the social isolation aspect is really critical. So we need to do the vast majority of the work to support people in this situation who have severe mental health conditions well ahead of those heat events. So doing a lot of prevention work and using the support and care infrastructure where they have routine contact, whether that's with primary care, community services, or with their social care networks or their neighbours and so on. So through mapping out the pathways, we're going to look at these are the critical pillars of what you do around heat risk management. So how can we reduce exposure? How can we reduce their vulnerability? And how can we increase the adaptive capacity, identifying where those routine touch points are? So in order to make that effective, we'll need to leverage in some research capacity to evaluate it properly and then look at scale. At the moment, I've no idea what that looks like, but the commitment is to explore it, because designing something separate is just not going to work. And the evidence is that we need to do something. So as I said, if you identify a big problem, a concerning problem, and you don't have a solution, then you need to design and evaluate one and take that as your first step. Thanks.
Thanks, Emer. And I mean, how exciting to hear sort of in real life, these actions being developed and implemented in a context such as London. So fantastic work and really interesting to hear more about it. Maybe given that we're sort of touched on this point around heat risk management and sort of people with severe mental illness, I know that there's been some wonderful work happening in South Australia, sort of on a similar note. So Kimberly, I'm sure again that working across climate and health policy for the state of South Australia, you have a lot on your hands, and you might also have a lot of requests in terms of recommendations and things to do. From your perspective and your context, what among the recommendations are the ones that you feel are kind of speak more clearly to your context and you feel would be need to prioritize?
Yeah, absolutely. So I will, as you've mentioned, I'll just give a brief shout out for targeted outreach, because that's something that we've already done in South Australia and we know it worked. So we have a heat health warning system which triggers proactive outreach during declared heat events. We have a telephone system which makes free daily welfare calls to registered people, explicitly including people living with mental health conditions. And carers and health workers can register somebody for this using a vulnerability assessment tool. So there's been some great literature that was published which showed a comparison between 2009 and 2014 heat waves. And in the in-between, this was instigated, and really showed quite a marked difference with really clear economics. So a single 1 week activation we've seen costs about 500,000 Australian dollars, with an estimated benefit cost ratio of 2 to 3.3. So saving $2 or $3 for every dollar spent, which is really quite compelling if you're making that pitch to finance ministers. So I think that is a really one of the key priorities. But I would like to talk a little bit more about monitoring and make the case for why that is not a boring answer. So right now we're really asking governments to act on something that generally we don't count. In the report, we talk about an analysis of heat mortality and morbidity surveillance across Europe, which found no examples of mental health impact monitoring, not a few, none. And the one national strategy that did commit to research and evaluation of this area was the US National Heat Strategy, which is now being removed from the government website. So this is a really key thing that unlocks everything else. It's not asking for a new surveillance system. And we know that most jurisdictions that have a heat health warning system, notwithstanding that a number don't, which we've talked about, But those that do are generally already counting ambulance call-outs, emergency presentations, deaths during heat events. And adding mental health outcomes to that existing count is an incremental change that really has quite a disproportionate return. Once we have that data, three things follow almost automatically. That risk now becomes visible to ministers, to treasuries, to decision makers, which is how things get funded. We're then targeting our outreach at people who really need it rather than a bit of a generic vulnerability list. And the last key bit is the ability to finally evaluate whether interventions work at all, which those of us working in this space know this is a real honest gap. We know this is doable. The UK Office for National Statistics has shown this is doable. They've built an indicator on suicides, which are attributable to extreme heat with published methodology, open access code. It's been endorsed by the UN Statistical Commission, etc., which is something that other countries can really pick up on rather than reinvent. So I guess my final call to action is really quite specific. Every jurisdiction that runs a heat health warning system should have at least one mental health indicator and should add this to its surveillance before the next season and publish it, just one indicator. I think that's really achievable. And I think that if this were to happen, it really moves that dial and changes the conversation quite significantly.
Thanks, Kimberly. And I think that touches also nicely on Nida's point about, if we're not measuring something, how can we then sort of act on it and respond to it, which I think is a really important point. I see, Francesca, you have raised your hand, so feel free to jump in if you want to contribute.
Okay, yes, I hope you can at least hear my voice. Can you hear my voice?
Yeah, we
Okay,
can hear your voice
because someone needs to open my video. Okay, now I can do that. Yes.
There you go. We can see you again.
Yes, thank you. No, sorry, I know it is unusual to intervene into the panel, but listening to you, there are two things that come to my mind. First is the last thing that was just said by Emma. If you don't have a measure or measures, you don't see the problem, and this is absolutely true. Because if I just think of how our understanding of the health impacts of climate change on health has evolved, the very first impacts have been those about when I bumped into this in 1999 the first time, okay? At that time, we were thinking of changing pattern of vector-borne diseases. Why? Because you have a very good monitoring systems that come from ministries of environment and so on, or from surveillance of vector-borne diseases. And there we had early evidence that, for example, ticks were moving north, were starting to appear more, in places where you didn't know them. So in the case of mental health, somehow we have to accept and to understand that it's the new kid on the block. And things do not happen instantly. If I just think of the WHO, we published our first policy brief on mental health and climate change in 2022. Which basically is the day before yesterday when you think, geological eras for public health. It takes a quite a significant amount of time between the moment you start having the evidence, you start knowing what to do with that evidence, and the moment you can put it on the policy debate, for example, in the form of a WHO resolution. And I'm speaking of these bureaucratic things because these are the things that at some point make into a Ministry of Health. So I just wanted to bring up this point for awareness. And Alessandra, I will just remind you that you were we invited you as a guest when we had the first under the EU Commission, the presidency of the European Union, the first time we had a debate, a public event on climate change and mental health was 2024, couple of years ago. So there is a continuum, and of course we need to accelerate because now the speed at which we are accruing the evidence is skyrocketing. So we need to accelerate the pace, but I just wish to bring this dimension of time and the time from evidence to action, policy and then action, that unfortunately we need to factor in. Thank you very much, and sorry for the intrusion.
Not at all. You're welcome to stay and to also, yeah, join any other, yeah, sort of questions that you feel you want to contribute to. Thanks so much, Francesca. And I think on this point, I mean, something that I've been, thinking about as we have written the report is it's obviously this tension between, as Kimberly mentioned, the state of the monitoring and of the evidence, but also the urgency and the fact that, as Samantha mentioned, we are seeing these sort of really incredible outcomes when it comes to some of the mental health impacts of heat. So I think one of the key messages that we really wanted to get across this report is that people aren't waiting for perfect policies. Innovative work is happening all over the world in communities, and we have 6 case studies in the report about these. But Samantha, as a family physician, you work really on the front lines of how climate change is impacting our health, the health of our loved ones, people in our communities. Could you share maybe an example from your own context of work at the intersection of heat and mental health that you're particularly proud of and that you think others could sort of learn from?
Yes, thank you. Yes, I am not a policy analyst, but I've really enjoyed listening to the policy analysts on this panel. My colleagues and I, when we learned about the BC heat dome data, which was published in early 2023, we decided we had to act. And so we developed an educational intervention for frontline mental health providers, people who work in ACT teams, assertive community treatment, and similar teams who work directly with people living with schizophrenia and other serious persistent mental illness. And so we developed a brief educational session, which, educated people attending the session on the signs and symptoms of heat-related illness, how to identify people who are at higher risk, and what to do in response. If a mental health worker finds someone experiencing a heat illness, what can they do? We also educated participants on how to connect people with free air conditioners through pre-existing programs in Ontario. And we provided template letters for the mental health workers to use to access this air conditioner program. And then finally, we also provided some stickers to give out to patients experiencing schizophrenia and other serious mental illness. The stickers leveraged a kind of treatment which provides reminders to people so that they said, "Am I too hot? Should I drink water?" We rolled this out to about 40 ACT teams in the summer of 2023 and the summer of 2024. And we just did a very simple pre-post survey, which showed that people learned a lot and they became more comfortable with their outreach. So I'm proud that we just did it and we proved that it was possible. It would be nice to have funding to be able to continue to do that work. But I think the main lesson really is just act as best you can. Or as Ayanna Elizabeth Johnson says, she's an American climate activist and marine biologist. What she said is, your climate work is at the intersection of what brings you joy, what you are good at, and what work needs doing. And so that's kind of what we did. And then I'll just add that something else that we learned was, in future iterations, I think it would be really important to involve people living with schizophrenia in the work. That's not something we had the capacity to do, but I think it is something that we're hoping to do, to actually roll this educational intervention out and provide it to people living with schizophrenia. And to do that, we'll bring in people living with schizophrenia to help us with the actual development of the educational tool.
Thanks so much, Samantha, and I mean, thanks for describing, what you've been doing in very practical terms. I was curious to sort of also maybe as a follow-up get a sense of kind of maybe what the impact was on sort of the kind of people living with schizophrenia that you were working with. Did you have a sense of what the impact of this intervention was?
Yeah, it's not something we measured, but we do have just anecdotally, I think we did connect a lot of people with air conditioners, which, you know, is a life-saving intervention. There are a lot of people who just were unaware of the program, even on the interventions, like the mental health worker side. And certainly people living with mental illness were completely unaware that they could access funding for an air conditioner. So I think I'm most proud of that, and I think that probably had the biggest impact.
Thanks. And keeping all my fingers crossed for, yeah, more research funding to, as you said, to evaluate and test these interventions. Wonderful. So sticking to sort of examples of interventions, another wonderful case study that you'll be able to read in the report is a case study looking at the provision of mental health support to people experiencing homelessness in New Delhi. So Ayushman, you've been doing this fantastic work in Delhi, which again is another city that just as we speak is experiencing another heat wave with perceived temperatures that was looking at over 47 degrees Celsius. And you've worked in, I think what's fair to say are some highly challenging circumstances, again, providing support to people experiencing homelessness during extreme heat episodes. So what do you think we can learn from the work you've done and your context?
Thank you, Alessandro. So yes, it is true. Like heat is part of our reality here. Like, earlier we used to have a summer season. It extends for like months and months now. So the communities that we work with are also like learning to like deal with this challenge and adapt to it in their own ways. But for us, just to give you a little bit of picture of like the situation of like homelessness in the country and particularly here in Delhi. So there are over like 300,000 people who live, in homelessness in Delhi itself, and most of them live on the streets. And these are people who have families. They are living in intergenerational homelessness. Often, like the children are being born into homelessness, and then it continues. The cycle continues, and most of them are living on the streets. And while we do have shelters here in Delhi, most of them are constructed of like shipping containers. So you can imagine during a heat wave, it becomes extremely hot. It becomes almost like an oven. So people even prefer to like, stay outside the shelters rather than inside it, especially during the daytime. And of course, like sleep is something which is a very difficult challenge for them, because even for people who are sleeping on the pavements, it doesn't even get cold till very late in the night. And so most people get sleep for 2 to 3 hours a day at the most. So that's why we decided that we wanted to do a study to create an evidence on how does like heat uh, affect the mental health of people who are living in homelessness. This was a follow up to our previous study that we had done, just to strengthen the case for measures for homeless persons, because that's a community that is very largely ignored in policies as well. And what we found is something that we've seen like everywhere else as well, that people reported high rates of like anger and irritation, and as well as like self-harm tendencies, and also the eco anxiety and climate anxiety of what weather is going to affect them next. So these are the challenges that people like shared with us in the survey that we conducted. But at the same time, when we were asking people how much of a challenge heat is for them, the first thing that they told us was that heat is not really like a challenge for us, because the challenge for us is not having housing or access to water or access to like other essential facilities which can be life saving. So they had been so used to like dealing with the other pressing challenges that heat was something that was on the back burner for them. But at the same time, they were able to tell us how heat is complicating and making these challenges even more difficult for them to deal with. So just for to get people to acknowledge that was a big step for us. And therefore, for us, what we wanted to say is that for any sort of like mental health issue, it's a structural issue in the first place. So people who are experiencing homelessness, they already are going through so many severe mental health challenges, and they're prone to mental health challenges, and extreme heat just adds another layer to it. So for us, like extreme heat and mental health became another fulcrum to demand our governments, our institutions, for adequate housing options for the people itself. And to start the conversation, what we did was that we decided to do a pilot. And what we did was that the shelters here are very like barren. Like if you see, it's all gray everywhere. It's not something that you feel people or families would want to live in. So to begin with, what we decided that we will just make the spaces more livable. So we introduces the concept of like, resting areas and play areas for children. So just to make the area a little bit more appealing for people to just live in, to just improve their daily mental health. And of course, address the most systemic challenges like, creating thermal comfort in the shelters itself by introducing like coolers, which are better equipped to handle large number of people, to creating like thermal barriers on the roofs so that the shelters don't end up heating so much, and also like advocating for more shelters in the first place, and as well as like making people aware of this heat as a challenge, recognizing those symptoms by creating like IEC materials, posters, um, and during the extreme heat periods, what we did was that we would distribute like relief material for people. This would include like all your ORS and all the electrolytes, as well as food, dry food packets, menstrual pads for people who need it. And so we created a kind of kit for people to use during extreme heat temperatures. So we approached it.
Yushman, I think we might have lost you. I don't know whether it's only me, but maybe we'll move back to Ayushman when the connection is gets back to us.
Essential services if we want to like address this issue.
Wonderful. Thanks so much, Ayushman. We lost, I think, just the last maybe 10 seconds of
Oh,
what you
I'm
were
so
saying,
sorry.
but that's totally fine. I think
Okay.
we got the sort of key message loud and clear, and I think in a way it's also kind of true to most sort of public health interventions, the idea that we don't necessarily have to reinvent the wheel when it comes to targeting health outcomes. So many of the interventions that we need to do, anyway, in terms of food security, housing security, are also ultimately interventions that will have huge benefits for mental health. So thanks, Ayushman, for that. I don't know whether.
No, and what I'm glad is that this report includes those in the recommendations as well, and that's something that I find is very, it makes the report stronger that we have also included those as part of the recommendations of the report. So yeah, thank you.
Wonderful. Thanks, Ayushman. I don't know whether anybody has any sort of reflections of what sort of other people on the panel have mentioned, or if there's sort of any responses or build-ups on what others have highlighted. Emer.
Yeah, I guess when I was thinking about what both Kimberly and Samantha said, the and it's not very pleasant to think of this as a financial quandary rather than a human one. But in the end, when we see that people with both severe and common mental health conditions, actually, which are very prevalent in the population, have not just an increased risk of mortality, but an increased risk of healthcare demand. So we see admissions and attendances. Those have an associated cost. And actually, my understanding is the admissions for severe mental illness during heat events are quite prolonged. So that means they are very costly. So if we are able to monitor, evaluate cost and put cost effectiveness, like quantify that impact of those interventions, then it may be possible to advocate for the sort of sustained funding that Samantha's program needs. So I guess when I said that, like, recommendation 4 is the one that I'm doing, so that's the one that I wanted to focus on. But we can't look at all of these things independently. We have to see it as a constant iterative cycle for improvement. Once we've identified this problem, we need to start thinking about like the end goal, whether we get to it in, hopefully not very long, but hopefully not 20 years, given the sort of geological timescales are very similar to public health timescales. I just don't think we have the luxury for that. But I think we need to think about the end goal being where we have public health programs that recognize heat risk vulnerability for people with mental health conditions and other heat sensitive conditions, and that the funding for that is sustained and is normalized and mainstream within public health and healthcare practice. I guess that's what I see as like the North Star for all of this. And how we get there will be through using all of the tools that we kind of describe in this policy report: monitoring, evaluation, working collectively, using the evidence effectively, and building the evidence, identifying scalable solutions, and so on.
Thanks, Emer. And I think we now have time to go through some of the pre-submitted questions, but also I've seen lots of different questions being asked in the Q&A section as our panelists were speaking, and please keep those coming. We're sort of looking at them in the background. I think one question that I thought was kind of interesting was many of you have mentioned sort of the importance of monitoring, and I mean, as Kimberly highlighted, however, there's been traditionally a sort of lack of monitoring of the mental health impacts when it comes to heat. And I was just curious to sort of maybe get some thoughts around why you think that has been. Why do you think it has been so difficult to measure the mental health impacts of heat in a way that informs, I guess, policy? So I don't know, Kimberly, Samantha, Emer, but also anybody else, whether you have some thoughts around that.
Yeah, absolutely. I'm happy to go first. Look, I think there's a lot of reasons, and we've sort of spoken about some of these. So the more hidden aspects, the stigma, all of these things around it. I think we generally, and I'm kind of speaking at this from both public health policy and my clinical hat, still we have a very difficult time having conversations around things that aren't very obvious. So even the concept that if we move away from mental health just for a moment, just to use this as an illustration, even the concept that heat will worsen cardiovascular disease, respiratory disease, etc., that person may not present with heat stroke, with dehydration, with a flag that says this is heat related, we still have a very hard time getting that concept over as well. I think for many people, that link with mental health and going, well, actually, there is a significant link. We do see exacerbations of mental health illness. We see all the impacts on medication. Many people just find that very difficult to comprehend. And I don't know that we have done, and I speak as the kind of the global policy education, we have done a great job to this point of really pushing that forward and making those links really explicit to a point where people go, yes, this is actually an issue. I know every time I bring up these statistics, we talk about things like the increased mortality with schizophrenia, etc. The people I talk to, many of whom are very health literate or working in the healthcare space, are just gobsmacked and go, what? Really? How? I just don't understand that. So I think there's a big awareness piece that we need to do as well.
Emer.
Yeah, I totally agree. And I would say that it's important to note that we really, really have not got there in terms of even the physical impacts, which are very large and really obvious now. So I don't know why I'm laughing. It's very unfunny. I'm just laughing at the paradigm here is difficult to understand. And I think when you think about mental health in general as a public health professional, the data and surveillance is a challenge anyway. So what do we use, like when we're trying to understand the global increases in mental health disorders in young people, for example? What can we use for that? We use surveys. Are they representative? Probably not. Do they tell us a snapshot out in time? Maybe, but probably very badly. There are, lots of reasons with that, which I'm sure many of you are aware of. And then when we look at service use data, that's only going to tell us about expressed and the available supply of health services. So it's a really inadequate measure of what mental health need and the extent of that need in the community. So I think that has played a part in this, and why in the end we end up with, and somebody's asked a very good question around why we look at suicide and why this is a very it's inadequate. I would agree with that, but in the end we end up with the hardest numbers because they're the ones that are easier to measure. So we end up with mortality and we end up with suicide. And it's our job as public health and other professionals to narrate that, to say, this is a public health iceberg. What's the size of the problem beneath that is X. We roughly think based on other evidence that we triangulate is likely to be X times bigger than that. And we see that in our admission statistics. And by the way, this is costing you so much per year and so on. So I think that there's an issue around heat and how difficult, like what's the baseline heat that we find acceptable in a global situation where our baseline is moving, what's our counterfactual. There's all these methodological things, but in the end, mental health conditions, both severe and common, and the outcomes related to that are quite hard to measure. And I think that is a challenge.
Thanks, Emer, and I'll definitely steal the public health iceberg metaphor. I think it visualizes so well, I think, how we often speak about heat and mortality, and how that, obviously captures a really tragic outcome, but sort of also hides the huge degree of impacts on quality of life and sort of
Yeah.
other outcomes. Samantha, I saw that you had, there you
Yes,
go.
yes, just briefly. I think also we're very lucky that we got that data from the BC heat dome that many of us have referenced. That's the work of Sarah Henderson and her group at the BC CDC, but it's also because the chief coroner in British Columbia happened to actively request that doctors in BC report any death that they thought was heat related. They made heat related deaths a reportable death. And that was a very active decision in the moment. They sent out email reminders to every doctor in British Columbia. And if they hadn't done that, we would not have this data. And, there are chief coroners in other provinces across Canada, for example, where I live in Ontario, who are refusing to do this. So anyway, I think it's just a call for, collecting the data because we don't know what we don't know.
Absolutely. Thanks. I know there's 101 questions that I'd love to ask, but we have, I think, around 5 minutes left for the Q&A. So I have a couple of things that I've noted. I saw a sort of thread in some of the questions around this balance between targeted interventions for people living with mental health conditions, often severe mental health conditions, versus these whole population universal prevention responses. And I just maybe wanted to sort of ask, in your own sort of context, how do you go about sort of understanding how to implement what when, and how do you sort of prioritize these very difficult prioritization processes? I don't know whether anybody has. Well, Emer, you go first.
Sorry, I'll jump in because I've just come out of doing this. So I guess there are two ways to approach it. In some instances, an opportunity might arise, but you're only really able to capitalize on that if you've done the legwork beforehand. So everyone on this call recognizes that this is a big problem. So if an opportunity, we've across this part of the world, we're experiencing a very hot summer. This is exercising the leadership across political leadership and health system leadership, and that means that there's an opportunity for engagement. If you have something that you think might work, if you have a good idea in your back pocket, now's the time to use it. But the other approach is the one that we took in London, which is if you don't know what to do and there are too many things to do, then you go through a systematic process. And I cannot recommend more strongly the heat health action guidance that the WHO has produced, because that allowed us to go through a legitimate process of identifying the key things that were feasible and that we could deliver collectively, and mapping out the opportunities and gaps, and to prioritize, which we have to do no matter what the context is. We have to be able to prioritize within the resource we have. So either have an opportunity in your back pocket and be willing to be horizon scanning for the opportunity to land that with your leadership, or go through a systematic process in which, when your leadership asks you what is it that you think I should do by this? Because that's the question that when I worked with my colleagues across the system in London, and we went out to the leadership, they were saying, yes, we recognize this is a big problem, but we don't know what are the key things we need to do. So now we have arrived through a systematic process at what those things are. And that has allowed us to get their buy-in and their leadership behind an endorsement for those actions going forward.
Thanks, Emer. Kimberly?
Thanks, Emma. Yes, I completely agree. I think I come at this from kind of a strange place because I act in both spaces, really. In the clinical space, our interventions are a lot more targeted and individuals based. But then, of course, in the public health space, that's very much that population level. I think one of the things which would be fairly common across, I want to say, most health systems, maybe there are some very lucky people on this call, but many of us are working in health systems which are just overrun, overburdened, overcrowded, too many priorities, not enough resources, really struggling with everything all the time. And I think for many people, it's, I can't do one more thing. Don't give me anything else to do. So it's about integrating these things into existing processes already, making the part of existing priorities. I guess two kind of examples. I think it's bringing mental health into the climate space and bringing climate into the mental health space, if we look at it in that way. So making sure that when we do have these heat health plans, we have one in South Australia called Healthy in the Heat, that we are naming mental health and associated conditions and all of the risks associated within those plans as an explicit group. So if somebody's picking that up, looking for heat health guidance, it is there, they can see that, then they can implement that as they need to in that public health policy space. Looking at the individual, there is and this is not, I don't think it's a conflict of interest, it's a convergence of interests. I'm involved with a project through Harvard University in AmeriCares called Climate Resilient Toolkits, which is information for clinicians and for patients, which has been implemented in many places in the US. We're now adapting it for South Australia. What that intends to do is to meet, let's take those clinicians as an example, primary care, emergency, you can include mental health clinicians in that. When they have that patient in front of them and they are seeing that patient within their context, so treating them for their mental illness, they can bring climate and heat into that, and they can have that conversation before we have a heat wave to say, you are somebody who is at particularly high risk. This is what you need to do. Do you have a cool space to go to? Do you have a support system? Did you know your medication puts you at a higher risk? So really bringing that into the existing care appointments that we already have and making it part of the conversation as well. So I think they don't need to be mutually exclusive, but we need to find ways to do this in a smart way that efficiently uses our existing resources as well.
Thanks, Kimberly, and thanks for giving us a very concrete example of sort of how to go about that. I think I'm probably going to pick my last question, and I think it's something that, again, has been sort of asked in the chat, specifically, I guess, to the South Asian context. So maybe Nida and Yushman, I'll direct that to you. But the question says that in South Asia, climate disasters often overlap with heat waves, floods, displacements. What are your thoughts on governments treating these as separate crises and instead focus on developing integrated climate and mental health policies? And I think, this is a question that rings true, even now in the European context, we're seeing how heat is, triggering wildfires and a number of sort of other kind of emergencies. So how do you think governments could sort of address these in an integrated way? Do you have any thoughts, Ayushman or Nida?
Yeah, I think I can start. I think polycrisis is becoming a real thing, especially people who are living in the global south. And we know that floods, extreme heat temperatures, landsliding, and so on, earthquakes. We have been facing all these polycrises very oftenly now. And with that, we know that we don't have the kind of resources that is required to actually deal with these multiple challenges. And I think the best way is actually to strengthen the existing programs and systems that we have. And it's not always necessary that we need to come up with entirely new systems, but rather than that we need to incorporate mental health into the existing programs. And we have seen that integrating mental health interventions into already existing programs and like community outreach programs, primary healthcare services have been actually beneficial. And so the healthcare providers, community healthcare workers, and frontline healthcare workers can be provided training to recognize psychological distress during heat waves. And it's not just the heat wave, but I think people also face a lot of mental health challenges when they are facing isolation due to floods and other forms of natural disasters. So I think that can actually be a really important aspect when we are thinking of providing basic psychological, psychosocial support, and also coming up with the community-based referral systems where needed, so that the people who are within communities, they also have this, trust with the communities and places where mental health is not something that you can openly talk about, and people are still very reluctant to accept and discuss mental health challenges. It is always rewarding to keep community health workers and local health workers in the teams and on board, and coming up with referral systems that can facilitate people who are at risk or who are at higher vulnerability and direct them towards the support that they need. I think we also need to understand the importance of lived experience in this context, because we know that scientific evidence do tell us that what is not happening. But even before these statistics like mortality statistics or morbidity statistics, they show up in our systems. People are living through those challenges in their daily life. And I think Ayushman said it really rightly, that people are aware that they are going through some sort of crisis, but they have so many issues that they don't just prioritize their mental health. They would rather prioritize having sufficient clean water supply, or having the daily food or the daily veggies they need to provide support to their families. So I think having public awareness campaigns is also a very important aspect. And we know there have been studies that even especially for context where people are not that literate, they don't understand the heat warning systems. It is really important to help people and communities understand that what messaging is being given, and it's very important to involve them in the first place in designing those messages. So I think with that, we also need to define what health risk means when we talk about heat, because this is where I think the biggest gap lies. We are still not able to, I know there's emerging evidence, but we are still not able to capture the mental health impacts of heat as we should. So we need to go back and define how we define health risk due to heat, and how we can monitor them in the larger sense. And I think involving communities in the adaptation effort is also very important, because communities tell, this way we also know, we know that there are interventions that work, but we don't know whether this set of intervention will work in a certain context. So this is very important, where we need to actually bring in communities, and where we need to bring in lived experience on a much more concrete, I think, way. And we just don't want to involve them once in the planning stage. We want to involve communities and lived experience throughout the processes. So I think the key to deal with such polycrisis in the low-income countries is actually strengthening whatever we have, the existing systems, the existing programs that we have. And I think this is the way that will take us a long way. Thank you.
Thanks so much, Nida, and thanks also for touching on actually lots of different things that were sort of asked in the questions, from lived experience involvement to community engagement. So thanks for that really comprehensive answer. Ayushman, I don't know whether you have very quickly some additional thoughts you wanted to share.
Absolutely. Just building on what Nida said, yes. So I think it has its advantages and disadvantages of treating these as separate crises. So for example, in India, each of these are considered as a disaster, floods and heat waves, etc. And they both come with their own separate budgets and their own plans. So of course it makes sense, also what Kimberly said, of integrating a little bit of climate into all the mental health policies, and mental health into all the climate crises. And we saw this during COVID also, how during the disaster, there was a lot of talk and a lot of action on mental health as well. But we don't see that in other disasters and other climate crisis that happens. But at the same time, also heat is getting a lot of attention right now in the policy space nationally also. So it's probably easier to start the conversation here rather than going into a full comprehensive thing. But that should ideally be the case of it being treated as one polycrisis, and mental health being an important aspect of that.
Wonderful. Thanks so much, Ayushman and Nida, for that. So we're getting very close to the end of the webinar, and thanks again to all the panelists for all your wonderful insights. But before closing us off, I'd like to finish this part of the discussion with a very quick round from each of our panelists. And I'd like to ask you, maybe in one sentence, what's the one thing you'd like policymakers attending today to remember when they're developing or updating their heat action plan? So maybe I'll start with Samantha, followed by Kimberly, Nida, Emer, and then Ayushman.
Well, I guess my one message was actually not for the policymakers, but for everyone else who's attending today, that you don't have to wait for the policymakers to implement new policy, but you can just act within your own influence.
Thanks, Samantha. Kimberly?
I don't know how I can beat that answer. That was great. I guess the thing that I would say is that for policymakers, heat is already a mental health emergency in every jurisdiction that's represented. The only question is if you write your plans to consider that to be true. So I think this is not something that isn't affecting you. You can choose to believe that or not.
Thanks, Kimberly. Nida?
Yeah, I think I would like to say that we need to stop treating mental health as a different compartment. It's not a separate compartment. We need to look at health as a holistic thing, and mental health is a very important part of overall physical health as well. And I think it's time that policymakers and everyone out there recognize it. So I think that's what I wanted to say. Thank you.
Thanks, Nida. Emer?
Difficult to follow that up. As I agree with all of the threads there, I agree we can't wait for policy to change. There are lots of things that can be done within individual roles, especially in frontline roles. The evidence is really clear that it's a problem. And I guess in general around climate and health policy, I would say that we really need to move away from trying to describe the problem in more detail. Yes, there are evidence and data gaps, and we've covered them today, but actually we're in the implementation gap is our biggest challenge, and we cannot afford to wait for another 20 years. It's a complex world we're living in, and one that's shifting, where the goalposts are moving all the time, given the instability in the environment now. So we just need to start making decisions and move beyond that kind of inertia. And this is definitely an area where the evidence is absolutely sufficient to move to action. Thanks.
Thanks, Emer. And Ayushman?
Yes, so my message would be that, extreme heat disproportionately affects those who don't have access to resources, who are already marginalized. And therefore, if we need to think of mental health and addressing that, we need to thinking of it as a structural issue and addressing the underlying causes that, affect it. And only then can we deal with this crisis.
Wonderful. And thanks so much, everybody. Again, I think I'm also moved by how you, I think, each brought your own sort of like personal experience of working in this space, throughout your comments and also in these final set of suggestions and recommendations. But this brings us to the end of today's webinar. Thank you so much to everybody that joined. As a team, as Olivia said, we have worked on this report for over the past 9 months. So we are really incredibly grateful for your time and engagement. And we hope that this discussion was useful to you and that you will be able to use this resource in your work. Extreme heat is not going to go away, unfortunately. We know that temperatures will continue to rise globally in the years to come. And with that, the impacts of extreme heat on mental health are likely to grow across the world. I think what I take away, however, from today's discussion is that even though we are really facing unprecedented challenges in the context of mental health, but many other health outcomes, there's also many solutions available which are being implemented around the world. I really loved hearing from our speakers how across so many different types of stakeholders, from policymakers to practitioners and communities, they all have such a critical role to play in ensuring that mental health is protected as we adapt to a warmer world. So again, whether you're an advocate working to ensure that heat policies consider mental health, or policymakers developing heat action plans in your city or country, or just someone working directly with the communities affected by extreme heat, as Samantha said, we hope that for everybody will join us in turning these recommendations into action. I'd maybe like to finish just by asking all panelists, as well as Francesca, but also Emma, Neil, Nikita, and everybody else in the back end, to maybe just turn on your cameras, as this has been just such a fantastic team effort. And I'd like to really take a final chance to thank you all for your fantastic work and for your support. So thanks so much again, everybody, for joining today. And we really look forward to continuing this important conversation together. So thanks, everybody. Bye-bye.
Thank you.
Bye. Thanks,
Bye-bye.
Thank you.